speaker, who is Stephen T. Parente. He's a professor in the Department of Finance at the University of Minnesota. He has a lot of experience in healthcare finance and economics, and that is underlying a lot of things about how we're designing healthcare. He's had roles with the White House and the Department of Health and Human Services. For those of you from Europe, that is basically the health department that's setting the policy and the payments. Very big deal, obviously. And Stephen has been the principal investigator on large funded studies regarding consumer-directed health plans, health information technology, and health policy microsimulation. And if I could just, as a point of personal comment here, say that for those of you listening in from Europe, in the United States, very often your healthcare is tied to your employer. So if you're switching jobs every year or every 3 or 5 years, you are then with a new, you're now with a new health insurance. So the long-term cost benefit is usually not, there's not a closed system unless you're with Kaiser Permanente. So just want to say that in terms of one thing to think about, the very different system than in Sweden. So take it away.
Well, thank you so much for having invited me to this. This is really a special treat for me. Actually, I visit Sweden quite a bit. We'll be there this year. I've been running a course with Karolinska Institute for the last 10 years called the Medical Evaluation Laboratory, where we look at early stage medical technologies. By all means, chat or email me after, and happy to connect with people more directly there. So I'm actually going to, let me share screen and show you, let me get this right. There we go. I appreciate getting, let's see if this works. Appreciate having at least a preview about being said about how the US is different, which is quite different. And I'm going to give a talk that's a little different than I think what most folks would have in terms of where I am. As mentioned, I'm a health economist. Actually, mentioned I worked at the Council of Economic Advisors. One other call out to Sweden, Tom Philipson was my boss. Tom Philipson is originally from Sweden, also a health economist, and we were engaged in a lot of the work that happened with COVID to begin with. And some of the work that I'm going to talk about here actually came from that work that I did while at the White House, actually with Tom's leadership. I'm going to talk about a topic that is new in the United States, but I think can be, as I put in my slides here, a Trojan horse, if you will, a mechanism to make health AI work better. So, and welcome any comments that are there. I'm going to, first of all, just talk a little bit about what I would say are essentially effective health AI prerequisites. This is coming from me as an economist, but most of my background really is in healthcare finance and insurance. Mostly in the US, but I also teach programs around the globe as well. The US actually accounts for about, for better or for worse, half of an $8 trillion world economy, close to $9 trillion. And so it does have some value in that space. But also these market-oriented reforms do find their way across the globe, depending upon the country that you're looking at. Part of it is really driven by sort of to the extent the consumer is engaged in care and where they want to seek for it. If it's a well-developed social safety net like what Sweden has, other parts of Northern Europe, it probably doesn't matter as much. But you never know. To the extent that medical tourism or sense of buying healthcare someplace else comes into play, then it may be relevant, if nothing else, for sitting a business in that place. These other things I'll talk about, there's from the White House, we had a transparency executive order. That's what's going to drive a lot of what I'm going to show you. Talk about what we call claims data, health insurance claims data. That's the biggest database that really operates in the US. It's used for a lot of health economic studies that justify payment in the US, and then that might drive the economic studies that go on for the rest of the globe as well. And then talk about this idea of healthcare transparency, price transparency, and how that sort of works. So when I thought about this idea about health AI, and I thought about it as a health economist, but also someone who teaches courses in this space as well, of health IT, health commerce, and things like that. These are kind of the priors that I had in mind. Like, if you're really going to do this, you need to have large health data sources that are close to real time. I mean, anything that you folks have been talking about earlier in the previous panel presentations about getting genomic information, integrating it in, linking, all that fits there. There's also the issue about, what consumers, the patient, what's their engagement and trust for this? How much do they believe in it or not? The third part, validation by medical experts. If the physicians, nurses, doctors don't validate or use this, it's not going to be very helpful. There's also the question about what scientists and particularly regulators think about this, to the extent that AI is producing a clinical outcome as it relates to cancer, for example. The Food and Drug Administration in the United States really will go heavily against that. It'll get the most regulatory scrutiny you can possible, because to have obviously a false negative, false positive for cancer could be a real problem. And then the big thing is, like, what is the business model for sustainability and growth in this space? We see AI all over the place outside of healthcare in terms of how it can be essentially an efficiency engine, whether it's web bots or things like that. In healthcare, it's not so clear, just because so many things in healthcare have failed to really achieve like the IT equivalent of Moore's law, where more processing power, costs go down. In all likelihood, in the US and other places, healthcare costs generally go up rather than down. So I thought, as appropriate, why not let AI tell us what the prerequisites are? It's actually really kind of amazing how effective ChatGPT can be. I actually just wanted to compare my notes with theirs. And so some things are there. They actually immediately talk about data quality and data privacy and security, ethical considerations. I thought that was kind of interesting that AI would be talking about its own AI concerns. Regulatory compliance, as I mentioned before, a lot of this is a little bit of word salad, but it's not wrong necessarily. Interoperability, basically having data works. And that's actually, in my mind, one of the biggest challenges in healthcare, is getting consumers and/or regulatory bodies and/or insurers, payers globally to have their data move. We know that it will happen in a clinical trial and a research setting, because it just has to by the nature of doing that research. But in terms of actually doing it for care management, a lot of data is very siloed, and depending on the country, too, in terms of privacy regs are different country to country, whether it be within the EU or around the EU. Even differences within the EU could be problematic, let alone talking about Southeast Asia, how it relates to the US, et cetera. User interface, that's just my way of, I think if consumers don't use it, it's not there. Scalability, same thing. Actually, my points aren't that far off from where they were. It's like, if it's not going to be profitable, it's not going to work. So, as mentioned earlier, I work in the health insurance space, and also mentioned the employer data, or the employer market in the US is massive. Most of healthcare finance, and probably the most profitable part of healthcare finance for paying for new innovations, comes from employer-sponsored health insurance. What this graph is showing is all the different types of health insurance designs that are out there. HMO is the Kaiser Permanente model. Think of that as a sort of a private sector version of the British National Health Service. That has been eroding, as you can see here, over a period of time. The most dominant form is what's called a PPO insurance design, which is where there's a negotiated price with physicians and hospitals that get paid. There's some sort of cost sharing that goes along with that. But what I want to highlight is the one that's actually, I do a lot of research in, that's been growing since 2006, these high deductible health plans. These are essentially really like a regular insurance plan, like any one of you who buys auto insurance for your car. There's a deductible, and then basically after the deductible, the work gets paid. This is really the same thing for healthcare. You might say, well, what are all these other things? Kaiser, they hire the physicians, they employ all the staff at the hospitals, they actually own the buildings. PPO is just basically buying essentially health insurance, really like a Canadian system. In the case of high deductible, it's just a much more basic form where there's just by the nature of the cost, the premiums are lower. And you have to pay a lot out of pocket before insurance clicks in, just potentially like car insurance. But the more out of pocket you have to pay, the lower your premium. Thus, the more affordable the health insurance in the US. This is another way of showing that this has actually grown over a period of time. This actually looks at all different types of employers in terms of more recent data. And my point of all this is that if you have high deductibles, you have an incentive to shop. Now, another way to look at this in terms of a global economy, India is becoming, and is now the largest, basically developing or developed economy in the world, surpassing China. India operates on a cash economy. And so price matters in that sort of setting. Singapore is small, but they basically operate the same way. They have high deductible plan for everybody, and then sort of a cash system and health savings account to buy in. This is growing in the US. It's the cheapest design in terms of offering stuff. That's why that orange chart was growing. Question is, what tools can you use to shop? So flash forward, or flash really back to 2019, I worked in the White House. There was an executive order. So this is where the president can issue something that's not approved by Congress or legislation. As long as it doesn't conflict with existing law, it can stand. And the idea here was to produce data that could actually help consumers know what medical care prices are, because honestly, right now, they don't. It's all opaque. I know that's hard to imagine, but just to give you a contrast, in Switzerland, where I've done some work, all of the prices that physicians get paid, regardless of what private insurer in Switzerland that they're using, is determined by the government, or at least determined by a brokered arrangement between the government and the medical authority. There is no variation in a price for a colonoscopy or a coronary bypass procedure. It's always the same. In the US, it is not always the same. The price variation is across the board. It's one of the things that, if you're from the outside the US, is just so vexing and complex. And some of the prices are transparent in the sense of Medicare, Medicaid, government programs post some of that. But if the private insurer, where most of the money is, if you're trying to start a business in the US to get paid in the US, it's just not there at all. This executive order basically sought to change that and force the insurance companies to disclose all their prices every month. This was fun. This was actually kind of fun. I actually worked, that was my view from my office in the White House. So just, it was a fun time to be there. I actually bought this model of an airplane there and had people sign the wing, kind of wishing me well. So that was including Tom Phillipson from Sweden. Okay, so I'll be kind of quick about this. Basically, there are lots of things in over a period of time to say you need to start negotiating, or at least start posting your prices. There was also a provision to develop a database that could be used for AI, that's synthetic though, so it doesn't have privacy concerns, for people to understand how the data could be used better. More on that in a second. It got some notification, one of the quotes there from the Wall Street Journal at the top saying that people did not expect this to be as far-reaching as it was. For me, who worked in insurance companies before I became an academic, it was kind of like asking someone, almost like you're a spy, like, tell us exactly how to get the data that we want so badly. I kind of knew all the places you needed to get it to make this work. You might say, does this really matter? This is a graphic representation of the US, just to show what the price spread is. These are essentially ratios. So Minnesota, where I'm based from, basically our prices are 160% higher than the national average. Wisconsin, 190% higher. That might seem odd to you. You might like, boy, I thought Minnesota was really frugal and innovative, and why is it so much more expensive? Partly is that if you compare this to government prices from Medicare for the elderly, Medicaid for the poor, it's the exact opposite. We are efficient for the government stuff, but we actually try to make up the difference with the payments for the private sector. So this is impossible to read, but I'm just going to show you. This is what came out of the executive order already for some for surgical procedures, just to show you the difference here. So this is showing you for, say, a removal of a breast growth, say cancerous. In the US, it's $3,500. That's the median price that's there. This is coming from 1,000 hospitals. If we go just from the percentile of 10 percentile to 90th percentile range, it's $847 to nearly $10,000. That's the range for the exact same medical procedure. And this is the rate that the government has, $2,800. So that's literally about 35% off of what essentially is happening. So if half the country gets paid by Medicare and there's these ranges, it's a hard world to operate in. And just to put this in perspective for medical technologies, any medical device that's associated with any of these things, and many of these are high surgical procedures, all have to be reimbursed within this procedure code. That's the relevance back to payment. Switching gears, are consumers ready for this? So we actually did a survey, a colleague of mine at another university, basically saying, to what extent does it matter, is price matter? It turns out price matters a lot, whether it's primary care for office visits, MRIs, newborn surgeries, et cetera. The other question that was interesting was, if you have insurance, do you have to look for pricing? Does it matter? We found that 45% basically says, I don't really have to compare prices because I have insurance and it's all basically going to be the same. Which actually, if you didn't know much about this at all, I didn't even have the data, I would probably say, well, it makes some sense. But as it turns out, with the data, we realized that's not the case at all. And then there's this other question I'll draw here saying that when you ask people, say if a healthcare costs for a test is $100, how much do you think it's going to be a different price point? And basically, you're finding that essentially 78% think that it's going to be less than 2 times. The data I just showed you that it potentially is up to 6 or 7 times greater in terms of for the exact same technologies. So research I've done recently actually tried to use some of the data that we got back to say, are we ready? This is part of the executive order. This is the part that specifies that there has to be an AI-ready synthetic database built from the government for people to use. Email me later if you'd like to know where it is. And just to basically accelerate the use of some of this very complicated data. If you have to buy the data, for example, from an insurance company in the US, it costs you at least $250,000. So I actually published some of the results of showing if you had this data, what would it do? How much could you actually save in terms of cash prices versus negotiated prices? Bottom line, $80 billion. It varies by different parts of the US. This is really just comparing what the savings are likely possible from the negotiated rates based upon data that we know from already that's existent from that synthetic data. Now, the US economy is $4.3 trillion, so it's like 80 billion, it's not so much, but in 1 year, anything is there. For those tracking US politics, 80 billion is just $10 billion shy of the Ukraine, Israel, Gaza, Indo-Pacific aid package. And moving on. So if this is going to work, the whole idea of basically having some element of AI being useful, my thought is it has to be in apps. It has to be in our phones, right? So to make that work, we need some apps to be able to drive this stuff. And the Wall Street Journal, major prominent publication, basically called this out, even got a nice quote in here, saying like, now this data is being published, what could we do with it? But it's really complex. And one of my comments back was that this stuff is there for tech to use, whether it be any of the major tech firms that are in play to basically harvest the data. The thing about it is that the insurers are clever people, and so they decided to make their data, even though the structure is simple, as messy and as large as they could. So they put it out in terabytes of compressed files. Just to give you some perspective here, this is what the leading health insurers in the US, United, Anthem, Humana, have put out for the size of their files in terabits for 1 month. This is the Library of Congress's in the US's entire digital library. Somewhere in here, yeah, here's the entire Netflix high definition catalog currently in existence. So you get the idea that some of the data being put out is just a little bigger than we thought this would all be. In terms of number of files, they did it by insurer, combination with employer. So here's United Healthcare putting it out. This is on their web. There's no CAPTCHA. They were required not to use any CAPTCHA. You could just get it. There's no fee. There's no user agreement, nothing like that. Here's file number 1 with this particular company called Global Chauffeured Service. And here's file number 3,999. That's what makes this challenging. Each one of these is a file you have to individually download. So unless you're really good with JavaScript and have a supercomputer at your service, you're going to have trouble doing this. Fortunately, in Minnesota, we do. So this is just one quick illustration. Like if you're really going to try to find the Trojan horse, and this is, sometimes when you're an academic and you're sort of a policy entrepreneur and working in the White House, and you're like, if this isn't moving fast enough, because my original paper said by 2025, we're going to have all these other things. Well, we're there and we're not quite there yet. This was my way of saying like, well, come on, people, let's go. And I call it my MedVita. So full disclosure, actually, I have moved with this to actually try to make this happen because, why not? There's other people in the startup space. So all this stuff I've talked about before, consumers, why doesn't this work? Consumers don't have an incentive to shop because prices are relevant, either because they're in a country where everything's paid for, or they just don't know. And so there's no tools to help them. Health savings accounts and high deductible health plans have been around, but basically there's not great tools for that. And so the thought is that consumer health assets are not, they're not easily transferable. You can't necessarily transfer an option for an organ transplant to make that happen. Insurers might, but that's not what consumers can do. And so one thing that actually makes this happen, and for those interested, I have a whole paper that actually goes into narrative detail how all these things come together, is that there are new regs in the United States that says patients own their own data, including all their insurance data. So literally insurance data that's on me for 20 years or so, actually 10, I can definitely get for free. I can request that from the insurance companies and they have to give it to me digitally now. That's new. There's what I already showed you is number 2, there has to be price transparency data. The last thing that's kind of interesting is that we change high deductible health plans to basically make preventive care for free and secondary prevention as well. So if I have diabetes and I need insulin, that can be for free now, or at least little or no cost. That was even before President Biden passed legislation for the $35 insulin. This was in place, but granted, it's for a certain type of health plan. And this FHIR, F-H-I-R, that's how it's pronounced, is basically a way to do interoperability. Helps, but has to be enforceable. So I should be done in about 2 minutes just to give you a sense of time in here. The idea is that there's 3 different ways that these things come together. MyMed basically harvests all this data that's been out there so people can put it on a phone. The thought is with that, then you have MyVita, literally putting all my health data together. And then MyTime is where the AI stuff really gets to be interesting, which is like, if I know what the prices are, if I know some of my history, and other people put their own history in as well on a platform where they've all signed in essentially a user agreement, you can now start shopping and saying, hey, what should I be worried about, thinking about in the future for prevention, for care, for scheduling activities as well. And so the question is for sustainability, because I'm in a business school, how does this work? MyMed, there's going to have to be clicks for ad revenue and things like that, or basically a subscription service. MyVita sold initially as freemium, but then if you want to actually add more data to it, clicks, because what's interesting is once you have the health insurance data that says, here's your lab test that was done on this date, you could then go to the next level and say, well, put my results in there too. And since you've given consent for that, you can share that with your medical provider, at which point you have something that the US really doesn't have in any real way at all. On your phone, on your smart pad, you actually have your electronic medical record. And with that data, you can then actually have that data be used for AI applications, again, with user consent. And then it's actually, you can also, this thing of MyTime, you can use it to actually schedule visits. Now, granted, in a country where everything is, covered, maybe that's not there, but, there are other parts of the EU or different newer countries in the EU where you still have to wait in line. And the thought is it depends on countries' cultural values, whether you want to pay to jump the line, but to the extent that this is essentially part of that could happen as well. This is, again, where I started everything out. The thought is if we get large data sources, and granted, this isn't the clinical stuff, but essentially all the things that get into clinical get you closer to that area. This gives consumers some engagement to sort of see what's going on because healthcare is expensive and they want access to it. If nothing else, the medical paying for it out of pocket, maybe the time cost of waiting can really be an important part of it as well. The validation by medical experts, if physicians get to see this information as well and make sure it's okay, it's all right. And to the extent that the regulators get to look at it as well and realize that it's not being used for decisions, whether or not you have cancer or not, but just to let the patient know what's going on so that they can work with the providers more effectively. And there's a business model. That is my presentation. Hopefully that wasn't too long, but it's a different flavor for what we're talking about, but I think a really rich opportunity. Thank you.
Absolutely. Thank you so much, Professor Parente. That was very interesting. Sorry about the phone. And I look forward to talk about this on the panel as well. I don't know about everyone else, but I would sign up for my MedVita now. I think that's a great idea, but no, understanding the financial part of it in terms of what's driving it and that people are really not aware of the price differences. It's huge. So thank you for unpacking that for us as a complex subject, and I love how you did that. So yeah, you will be part of our wonderful panelist discussion, and I'll see you back then. Thank you.